Welcome back to Season 3. This season we'll be looking at a new aspect of sustainability, the healthcare sector. And so, our season title is A Manifesto for Surgical Health in Africa. I have invited Professor Bruce Bickard to host this season, the first time Earthcast will be hosted by someone other than myself. Bruce will unpack his new book through interviews with African and global experts in the field who helped him write it.
Good evening, everyone. Thank you for joining us for episode 2. This follows an introductory episode which I had with Olivia. And this is the first episode where we actually start to discuss the book. So in this episode, we'll discuss the first part of the book, which describes the current state of surgical outcomes in Africa. My guests today have extensive experience in providing surgical care in Africa. Sue Fawcus is an obstetrician, and Agya Prempeh is an anesthesiologist. I'd like to introduce them. So Sue Fawcus is a senior research scholar and professor emeritus in the Department of Obstetrics and Gynecology at the University of Cape Town. She is retired from 25 years as head of obstetric services at Mowbray Maternity. She is a member of the National Committee for Confidential Inquiry into Maternal Deaths, with the responsibility of analyzing all deaths due to obstetric hemorrhage and deaths related to caesarean section in South Africa. Agya Prempeh is a Ghanaian colleague who is assistant professor of cardiothoracic anesthesiology at the University of California, San Francisco. He is the author in the acclaimed Kaplan's cardiac anesthesia textbook, and he has also served as a project manager for the African Surgical Outcomes 2 trial with me. So Sue and Agya, you both feature heavily in the book, and you've both been close collaborators with me in our work in Africa. So thank you for joining me this evening. I would like to start this episode with a short reading from the book about you, Sue. And this, I think, gives the listener some context about your initial work in Zimbabwe and probably helps people understand why we have the outcomes we have in Africa. So Sue Fawcus's first caesarean section in a district hospital in Zimbabwe was for cephalopelvic disproportion. Basically, the baby was not going to make it out of the pelvis vaginally as the head was too big, and the mother therefore required a caesarean section. At about midnight, after the porter had fetched the patient, he waded across the river to turn on the generator to power up the operating theatre for the operation. A final year medical student proceeded with a spinal anesthetic and then donated some of her O-positive blood as the mother's hemoglobin was already low. The medical student was not only the anaesthetist and the blood donor, but she was also the pediatrician and quickly moved around to catch the baby after it was delivered by Sue, so that she could dry, warm, and stimulate the newborn to breathe. This mother and child had faced many hazards, but fortunately both made it through unscathed. No dedicated anesthesia or pediatric care, amongst numerous other risks including potential blood reactions and a relatively inexperienced medical team. In most district hospitals at the time, the same doctor administered the spinal anesthetic and then went on to perform the surgery, with the patient's vital signs and anesthesia being monitored by a nurse. In resource-limited environments, healthcare workers at the coalface are continually balancing risks. I think, Sue, this is quite a strong story, or powerful story of a young doctor providing care in Zimbabwe. Can you tell us how this influenced you and your future career?
Well, the background was I'd previously started my training in the UK. So in London, I'd been exposed to a kind of teaching hospital maternity care where it took a long time, before you were allowed to do a caesarean section on your own. And you always had quite a senior anaesthetist with you. And I hadn't been in Zimbabwe very long, and I just happened to be visiting this district hospital, more like on a social visit, and then discovered that they needed someone to do a caesarean section in the middle of the night. And the main doctor wasn't there. There was a medical student who had learned to do an anesthetic, and we had to sort of make a decision. Do we transfer this mother with obstructed labour so 5 hours by road to Harare, where there was a central hospital, in which case we weren't sure the baby would make it, and the mother could rupture her uterus. So we, pragmatically made a decision to do it there and then. I must say, part of the team was a very experienced midwife. And I would say she was the sort of the wisdom and the continuity. And we were both kind of quite young, but she sort of knew what she was doing. She'd assisted at lots of cesarean sections. She sort of organized everything. And we then proceeded to do it. And I suppose how it influeînced me was coming from the UK, just the huge inequities, that here a woman was having what was really a life-saving procedure for her and her baby done by two very inexperienced people. And I must say, we were incredibly lucky that everything was all right. I would say, I did have reasonable skill, probably more than the medical student who did the anesthetic. But if something had gone wrong, if she'd bled, then, we really wouldn't have been able to manage it, and the mother might have died. So I think it illustrated what I think you say in your book about the inverse care law, that people in poor countries, the care that's provided to women, which is often needed much more, is kind of inverse quality to that what you see in a high-income country. So it really told me a lot about inequities. And it also showed me this paradox. I'd come from the UK where women were complaining about having too much intervention. Obstetricians were doing too many Caesars. And suddenly I was in a situation where people just didn't have access to what were the very basic requirements. And I think it was a big eye-opener to me about inequality. And also showed me that, you've got to look at what's happening in the district, in rural areas when you're working in an African environment. What happens in the teaching hospitals is often very different.
Thanks, Sue. I think you summarize a lot of the issues which are discussed in this first part of the book. Lack of access, and then the fact that in the district hospitals, often very little's happening, which means like very specialized surgeries and that are drowned out, they've literally disappeared. And even though most surgeries in Africa are cesarean sections, in fact, hardly any women or very few women are actually getting the cesarean sections they need. And your experience, fortunately for you and the medical student and the mother, had a good outcome. We know in Africa that if you have a cesarean section, you're 50 times as likely to die than if you had a cesarean section in a high-income country.
It sort of taught me something, and this is two-sided, that when you're in an environment like this, you make a plan and you use the resources you've got. And so nurses give anesthetics, clinical officers do cesarean section, and that's often good, because if that didn't happen, there'd be no one to do it. But when you make a plan pragmatically, there is an issue, a slightly ethical issue. Are you sometimes giving women in Africa second best care? Do you know what I mean? You do what you can do with available resources, but women, wherever they are, deserve more. They deserve the best care, because why should a woman in Africa not have? And so I think that is another paradox, that you do what you can, you make a plan, you use the resources you've got, but does the woman deserve more? And I know when I arrived in Zimbabwe, there was this kind of thing of see one, do one, teach one, in terms of cesarean section. And actually, it's a very arrogant colonial attitude, as far as I can see, that you come here and you can say that, when I think women deserve much more.
That's great, Sue, because I think, essentially this book and these podcasts are really, it's about advocacy for safer surgery in Africa. And so, yes, see one, do one, teach one, in reality is actually what we're trying to avoid. We're trying to move to a point, that there is health equity in Africa, and we know at the moment there isn't. I think it's probably good at this point to bring Agya in. So Agya, in the book, I recount a story that you told me when you spent the whole night at a patient's bedside. Patient was obviously septic and you were pouring fluids in, looking after the patient, getting antibiotics, and then in the morning your team couldn't believe your patient was still alive. And then you went home, and when you came back, your patient was dead. And I had a very similar experience to yours when I was an intern, very similar. And really the reality is that there are just not enough resources, and that when a patient complicates after surgery, for example, in Africa, they're twice as likely to die than anywhere else in the world. And I think, Agya, we went on to do the ASOS-2 trial, which was trying to increase surveillance for patients who were complicating, and you were obviously the project manager. How was that experience of trying to create change and increase surveillance to decrease mortality following surgery in Africa? How did that affect you?
Well, let's go back to the experience I had, because I think that was a turning point in my life, because up to that point, I was considering being a neurosurgeon or a neurologist. All right. So now I come on call in a surgical medical emergency, and it was basically emergency room. And also I also had like beds that you could make it a ward. All right. So I come on, and this patient, a middle-aged patient, is septic, all right, barely could keep his eyes open. I think if you're in a well-resourced environment, he'll probably be intubated at the time already. So my colleagues basically felt he was a goner, because typically when you see patients like that back home at that time, it's like there was no point, because, you wouldn't get an ICU bed and the patient was just going to waste resources, in quote. So now they knock off, and I'm like, boy, this emergency room is full and this patient is sick. I'm only one person there, all right? Fresh, don't know much. So I grabbed my Harrison's textbook of internal medicine and I'm reading the current management at the time of how to manage a critically ill patient. And it was like, okay, get IV fluids. And at the time we're using normal saline, and now we know the issues giving large volumes of that. So I'm giving normal saline, manually checking his blood pressure with a swig, all right, compressing the cuff every now and then. And yes, I know at times it was 5 minutes, but at times I had to do it every minute. And I'm still looking for other patients who are also equally sick in the emergency room. And now we didn't even have epinephrine adrenaline in the emergency room at the time. I had to run across to the cardiac unit to literally beg them to get adrenaline to come back and give to this patient. All right. So now the other problem was his sepsis. How are we going to manage that? He wasn't responding to conventional antibiotics. And as you rightly said in the book, we had just finished a trial on meropenem, and I contacted one of my colleagues. This was like probably 11 p.m. at night. And he brought down some of the medications to me, and we started giving to this patient. And yeah, that's why I did the whole night, checking his blood pressure every 5 minutes, sometimes every minute, giving fluids, and yeah, running off to see other patients, coming back, looking at my Harrison's textbook, trying to figure out if I'm doing the right thing or not. And yeah, in the morning he picked up. He looked much better. My colleagues came back. They were happy. I felt good leaving. But unfortunately, reality dawned when I got back and realized that he had passed away, because people couldn't afford to give that care. And I understood, because we're stretched. You have probably about 50, 60 patients in that emergency room ward, and you are trying to help everyone. It's not possible.
You've touched on so many points here. Yeah. You touched on the point of lack of human resources, yourself, one person and 60 patients, the lack of resources, not being able to monitor the patient, not having the drugs that are needed, not having antibiotics. And then a normal day starts and other things happen, and then people even stretched even more. And unfortunately, patients die. And really, this episode is really about, how poor the outcomes are, unfortunately, in Africa at the moment associated with surgery. And the factors that you've brought up in this experience, which I think we've all experienced, are really some of the issues that we will go on to discuss in further episodes. And, what can we do to make surgery safer? I mean, It's terrible. Sue had an experience which fortunately turned out okay, and you had the absolute opposite experience where, you put your whole heart into it, and then ultimately the patient died. It was something that you could not control in the end.
Very true. I think for me, it shaped me, all right? And as I said, that night I kept thinking, that patient shouldn't have died, all right? And for me, it was like, if we had a functional critical care system, probably this patient will survive. So then I asked myself, what could I do? How could I enter critical care? So I looked at emergency medicine, I looked at internal medicine, and I looked at anesthesia. And at the time, I just felt that anesthesia touched on all the surgical disciplines, and I felt I could make more of a difference in Africa with anesthesia. Because at the time back home, for about 4 years, no one had even joined the residency training program in anesthesia. They all only had senior residents or registrars. They had no juniors. So I was like, you know what? I think this was an opportunity. And that's how come I ended up in anesthesia. And for me, that's been one of the driving things in terms of going out for your patient, because that makes a difference, all right? We can't say enough is enough, all right? What else can we do? What are the pragmatic solutions we can do for our patient based on what we have, all right? And I think that's where the objectives of ASOS tied in with my career objectives. And I was grateful to be part of that, because what we implemented were all pragmatic solutions for the good of Africa.
I think this dovetails quite nicely. You're talking about how specialties actually cross. And so, a big theme in this book is that healthy or functional health system needs functional surgery. And because it's a cross-cutting discipline, about 30% of all diseases have a surgical component to their treatment. And besides that, surgery then, because of the skills it brings, because of the surgeon skills and obstetrician skills and the anesthesiologist skills, it means they are reflected in other spaces in the hospital and the health system as well. Where we saw that, how some of the less resourced health systems broke down in COVID. And there are skills there like intubation and all sorts of things which come from some of these disciplines within the surgical space, which make a difference, which make a health system resilient. And I think I want to bring Sue in here, because Sue, you speak about, people perceive surgery as a specialized discipline. But in reality, I think you can explain well why the Safe Surgery Initiative would fit in with basically a primary healthcare approach to health.
Yes, look, I think the whole primary healthcare approach, which came out of Alma-Ata in 1978 and then was reinforced in 2018 at Astana, is really the sort of cornerstone of healthcare, particularly in Africa. And, basically it concentrates on providing promotive care, which is all about social determinants, which is important, preventive care, curative care, and rehabilitative care. And I think that a lot of the narratives have rather forgotten about surgery over the sort of 50 years. The idea of curative has been very much medicines, and people think that sort of surgery is something, as you say, a little bit more specialized. But actually, just as you say, and particularly in maternal health, cesarean section is the cornerstone. Safe cesarean section done at the right time saves 2 lives, mother and the baby. And we know in countries where cesarean section rates are only about 2% or 3%, maternal and perinatal mortality is high. So I think safe surgery fits really into the primary healthcare approach. And that's why I think writing this book is so important, because I think it's putting it there where it should be, as is the whole global surgery initiative. And I think the other aspect of primary healthcare, which is an approach, is that healthcare needs to be available to all people. It needs to be accessible, which means people need to get to it. It needs to be affordable. So a family shouldn't have to spend a whole year's earning funding a cesarean section, which can happen in some countries, and it needs to be appropriate. So we provide the care, I think, as Agya said, within the resources we've got, and we make our decisions appropriately according to needs. In that way, I do think a safe surgery, which saves lives, really fits into the primary healthcare approach. And I think it's so important that it's being recognised now. And I'm obviously giving obstetric examples because that's my background, but there are many more, I'm sure, from other disciplines.
So if we take this a step further, providing surgery makes a health system more robust or resilient. Similarly, in our environment, climate change is becoming a massive problem. And with that, it's going to bring further health challenges. Your challenges associated with adverse weather events, with flooding, with population displacement, infectious diseases. And so, even the poor outcomes that we've seen across Africa at the moment probably will get worse if we don't really, lock down a very secure surgical system to support the health system, especially as we can see there are going to be more and more health challenges with climate change. Do you think that's a fair assessment, Sue or Adja?
Bruce, I think it's an important topic because already in Africa, we have limited healthcare budgets and more so the surgical care budgets. So now any increased pressure on the healthcare budget will lead to a diversion of funds from certain surgical disciplines, all right? And I think with the climate change, it has the potential impact in a number of ways. One of it was, as you talked about, the increased natural disasters, all right? That will lead to money being diverted for economic recovery, all right? And also with that, certain companies might not be able to produce surgical supplies and we might lack surgical supplies. Also, if you think about air pollution from all these carbon footprints, that will lead to increase in cardiovascular and probably respiratory diseases. And now that will also lead to an increased shift in attention to these prevailing diseases as opposed to our regular surgical problems, which are already lacking from support. And also, when you look at the perioperative care, that's also going to be impacted. When you think about surgical site infection, we know there's a positive correlation between that and increase or warmer temperatures. And also, with the warmer temperatures, food supplies might be impacted. So you might have increase in malnutrition, and that can be at a child level or an adult level, and all that might impact on wound healing, which is also a big problem, especially in our obese population and our diabetic population. And also with this, people might end up eating more unhealthy stuff, and that also increase our risk of cardiovascular diseases. So if you put all that together, you have a disproportionate increase in number of surgical cases relative to the number of available specialists. And we know that in Africa, we have less than one specialist to about 100,000 population, which is significantly below the WHO standards of about 20 to 100,000. All right. So that is going to be a big problem. We need to be able to deal with our carbon footprint and carbon emissions, not just in other sectors, but also in the healthcare sector. So I know in my institution, UCSF, we no longer have desflurane on our vaporizers, anesthetic machine. We currently, nitrous oxide, we only get it through our e-cylinders, not through the pipelines. And I know we're also working to try and decrease our plastic waste. And I think these are important ways for us to reduce our carbon footprint, which is very, very high at the moment.
Absolutely. So I think, even though we need to increase access to surgery, increase the quality of surgery, at the same time, we need to focus on creating a greener surgical system as we work towards this in Africa. I know we're almost out of time, unfortunately. I feel like I could just carry on chatting to the two of you. So I've got one more question, really. Is there something I haven't asked either of you that you think I should have?
Just one sort of area that perhaps we haven't touched on enough, and it sort of links in, I suppose, with the climate change, is, we want to make the health system resilient and have available surgical care, but safe outcomes will only happen if we have a healthy population. And so kind of going one step back and looking at social determinants. For example, in maternal health, in our maternal deaths in South Africa, 40% of the women are actually anemic. And being anemic isn't good for surgery. You're more worrying for various reasons, you're more likely to get sepsis and bleed and suffer from bleeding. So I do think one's got to also have that kind of primary healthcare approach, which looks at the community. And particularly if you're looking at women, sort of adolescent health, if women have heavy periods, they're going to become anemic if they don't have enough nutrition. And that's all going to be made worse by climate change, because there we're going to have probably people aren't going to be able to grow the crops they normally would. They'll be displaced. So I think it's good to just have this perspective of providing safe surgery, but also having a lens which looks at social determinants, which improves people's nutrition and general health.
When we're talking about the inverse care law, and I think it's based on a personal experience. So I think the other question we need to ask ourselves is why is it that the urban areas are more concentrated with our specialists, and why not the rural areas? All right. When I was in Ghana, just before I left, there was this drive by the government to get the newly qualified specialists to go to the rural areas so that they could serve, and that would also help reduce mortality. But people were reluctant, and I think they were justified to a certain degree, because now you go to those places, there is no guarantee of education for your children. So if you have a family, your children might have low quality education. All right. You might have low quality of life because there's no guarantee of water and electricity having a constant supply. You understand? And also you might not have the support system that you need. So for me, I think government agencies need to come up with better solutions to support these colleagues who end up going to the rural areas, or making it more attractive for them to go to the rural areas without significantly compromising their lives and the quality of lives of their families.
I think the two of you have raised great final points, because I think that, the message is, as we go through the book and as we'll go through the podcast episodes, is that the continent needs healthy people, and healthy people need a functional health system. And to be a functional health system, you need a functional surgical component to it. And then it moves on later in the book about advocacy and that. And really this whole series of podcasts in the book is about creating an awareness of these factors and ensuring that, the community and the civil society are aware of these shortcomings in what we have in Africa, so that people can mobilize for really what is rightfully theirs, and they're not getting at the moment. So Agya and Sue, thank you for spending the evening with me. It's most appreciated. Thanks for influencing me and for everything you've done for people in Africa. Bye-bye.